Hi, I'm Jonathan Papson,
Hi, I'm Amali. Local gay.
and this is Cut to the Case. And I've got Amali here, so guess what? We'll be talking ultrasound today. And Amali, have I got a case for you? Picture this: we get a call from ambulance. A 61-year-old man's coming. It's about 5 minutes away, post arrest.
Yeah.
They tell us a PEA arrest. He's 61. They've got ROSC. They've got him back. They've got him on an adrenaline infusion. And he's sort of running on 10 mics a minute adrenaline infusion. They're not sure what happened. He seemed to have just opened a door, collapsed, fell on the ground, CPR for 5 minutes, then got ROSC. He's coming. We've now got 5 minutes. You're walking down the hall to the resus bay. What's going through your mind, ultrasound guru? What are you thinking?
Is the ultrasound on? And is it ready?
Because that's one of the things, right?
Yeah.
So,
and you don't want it charging and going, I am opening up for 5 minutes.
So fortunately, we've got ultrasounds in just about every resus bay. So the ultrasound's on. It's good to go. It's warmed up, ready to go. But what are you thinking? What else are you thinking?
So it's a PEA arrest. So you want to think about the 4 H's and T's and what are you going to be able to diagnose clinically? And then what are you going to be able to diagnose on ultrasound and on the story? So it's a 60-year-old guy, PEA arrest. So the first thing you think of is cardiac ischemic heart disease issues. And then you want to think about all the other things.
All the other stuff. So you know, has he had a PE? Has he got tamponade? Has he got a AAA? Is he bleeding?
Yeah.
And all these things are going through my mind as I get down there, and thankfully the machine's on, it's ready to go. Patient wheels in, there's no CPR in progress, 10 mics a minute of adrenaline. One of our registrars does a primary survey, doesn't find very much. Intubated patient, and not really much to find. He's looks old for his years, and but what I see, I'm at the end of the bed, and what I see is I see him. Paradoxical breathing is actually, it looks like a massive flail chest. He's had such good CPR that I can actually see.
But no trauma. He hasn't had any trauma.
So there's no trauma in the story. So open the door. Someone came to visit, opened the door, fell through the door, collapsed, gets CPR. But what I'm thinking is, oh my God, he's got broken ribs.
Yeah.
So I've got the probe ready to go. He's got broken ribs.
Yeah.
My question to you is, what do you do first? Post arrest, bit of trauma. Where do you start?
I still go straight for the heart because I want to know why he collapsed, and that's what you're going to fix. And the flail chest, yes, that's CPR probably. And if he has a pneumothorax, that's probably not why he collapsed. So I still go for the heart.
Yeah. So I did exactly the wrong thing because I'm thinking, oh my God, has he got a pneumothorax? So I had the actually, what probe should I had the cardiac probe on?
Yeah.
No good. Right?
No good.
So
the reason is because the echo probe has very bad superficial resolution. The abdo probe, linear probe, really good superficial resolution. So when you put the cardiac probe on the lung, you can see lung sliding, but it's not as good as if you had the other one.
So I switched to the, I think I switched to the abdo probe because that's my go-to normal probe.
Yeah.
I put it on, do the chest, lung slide is fine. Yes. I don't see pneumothorax.
Cool.
So then what do you do from there? Like, what's your next step? So, I've got the abdo probe.
Yeah.
I've done the lungs.
So just like you're doing an EFAST, you'd use the abdo probe then to look at the heart in the subxiphoid.
And is that going to work?
Yeah.
Is that as good as the echo probe?
Well, you've got 4 chambers. You can exclude a pericardial effusion. You can look at the right ventricle, see how big it is, and then you can turn it around, look at the IVC. You can do everything with that abdo probe.
So, and what I actually did was go, oh no, I need to go to echo probe. So I then wasted another 2 minutes, changing the probe thing around. I'm on the echo probe. Okay, so I can just use the abdo probe.
Yeah, in the subxiphoid.
In the subxiphoid.
Yeah. Or you can do parasternal, but have your probe marker towards the patient's left hip.
Yeah, which is always
get the parasternal line
kind of a bit confusing. What I did, I was on I switched to the echo probe.
But you've got time. He's not.
Yeah, I had time. We had time. But I had time. But again, the pressure's on.
Yeah.
Because I'm the ultrasound person, and people are looking to me to make a diagnosis. So kind of got time, but I kind of don't have time. Everyone's kind of waiting. What's the answer?
What do we do next?
So what do we do next? How do we go? So I'm on there, and I start with the parasternal. I didn't do suprasternal. I start with parasternal long axis, and This is what I'm seeing, Amali.
Yeah.
These are the pictures.
Oh, wow. Yeah.
Yeah.
Nice
yeah.
pictures.
So, good. Thank you. That'll be a first. Right. So I'm seeing this,
Yes.
and
so you've got
Yeah.
depression on long axis, and it shows that big dilated RV. And if you do the 1-to-1-to-1, which the RV
hold
aorta,
on,
LA,
1-to-1. What do you? Hang on.
so this is the ratio. The RV outflow,
Yeah.
aorta,
Okay. Yes.
and
No,
left
I did that.
atrium
Yes.
should be the same size, and
So-
you can
so
see that the RV is massive.
3 guys on the right, 2 guys on the left. Right. 3 guys on the
Right, should be the same
are all the
size.
same size,
Yeah.
and the 2 guys on the left is like 1/3, 2/3.
Yes.
That's how I'm thinking.
Yes.
Yeah, because I'm a simple kind of person.
Yeah.
So I'm not seeing that. No,
Yeah.
I'm seeing this big RV, and even I'm
that's
seeing
not
it.
moving.
So not moving.
Yeah.
Even I'm seeing it, and even I'm going
Yeah.
problem.
Yeah.
So I'm thinking RV overload, pressure overload. What's it going to be? So we're thinking H's and T's. What
Yeah.
are the possibilities?
Well, he's an old guy, so you always want to think in the back of your mind, is this chronic? And what I'm seeing is just a chronic thing, and it's not a
Yeah,
problem.
right. Okay.
But you can see that the RV is really huge and the LV is hyperdynamic, and so in a PEARS, that's a PE.
That's a PE, and
Yeah.
that's what I was thinking.
Yeah.
To be honest, I wasn't really thinking of anything else.
Yeah.
But because big RV, LV contracting well.
Yeah.
I didn't really think about the wall thickness, but
and then the other thing is RV infarct,
okay.
causing lack of output.
Right. So would that look the same as a PE?
Yes, without the pressure effect. So the septum wouldn't be bowing into the left
Yes.
ventricle like it is
Which
now.
is the next thing I did. So I got the long axis, and then I switched to the short. And then I'm seeing, have a look. This is what I'm saying. Sure.
Yeah. So you've got the big RV that's sitting on the LV like a stone. This is what I like to say. Like it's just sitting on it instead of draping across it like a water-filled balloon.
So it's kind of squashing.
Yeah, squashing down.
Yep.
The septum's flat. The LV's tiny and working really hard. So that's pretty evident of RV pressure overload. So the next thing then you want to do is go to the IVC and see if IVC confirms
which is
what
exactly
you're
what I
looking
thought.
at.
So I was so proud. I
Yeah.
thought, oh my God, I found this PE.
Yeah.
And we are seriously thinking thrombolysis.
Yeah.
But I thought, let's get a little bit more information. I've got 2 views. I didn't do the zip view because just seemed a bit hard. I didn't do the apical 4-chamber. I probably should have. But I went for the IVC, and then this is what I got.
Oh.
So what's going on there?
Yeah.
Actually, before you say what's going on there, I'll tell you what I thought.
Yeah.
I thought that IVC should be plump and full.
Yeah, and not
kind of
collapsing at
not
all.
collapsing, right?
Yeah.
Because I thought, well, this is the back pressure from the PE, right?
Yeah.
So, but I'm not seeing that.
Yeah.
And now I'm thinking, is he undervolumed? Is it something else? Is it some chronic RV dilatation?
So this is what I think, right?
Yeah.
It could be one of 2 things. It could be that PE is not a right diagnosis. This is old, because the RVC does look big. It's just not massive, right?
Yeah.
And it looks like it's collapsing a bit. So it could be that this is just chronic pulmonary hypertension. Or it could be that it's a submassive PE, like he collapsed because it was a massive PE, but now it's moved on a bit and there's a bit of flow around it.
Right. So that
There's a
makes
bit of
sense. And he certainly had pretty good quality CPR. Let's face it. I mean,
and he's stable on the
got
adrenaline.
broken ribs. So that may well be the case. That maybe that's what made sense.
Or it's that you haven't opened up the IVC. That's the other thing.
What? Open up.
So see how the IVC tapers in the middle?
Yeah.
So you're closing it off because of you're not angling into the IVC enough.
Right. So that's an actual technique thing.
Yes.
So if I'm getting that kind of view, I should actually alter.
Yeah, try and make
my
it come all the way across the screen into the right atrium, and then you know that you've got a good proper.
So without, I think what you're saying is, if I don't get the right view, I can't actually make a
call.
proper informed
Yeah,
call.
you can't thrombolyze someone on bad imaging.
Okay, good axiom. We were going to thrombolyze him, but he was now stable by this point. So we didn't. But what else should I be thinking? We mentioned the H's and the T's. This is a PE. What's the differential, and how come it isn't one of those other ones?
For the echo images you've got?
Or
for the PEARS?
Any guy like this. Yeah. What are the other, if there were, I don't know, 3 other things I should rule in, rule out, what would that be?
So rule in, rule out pericardial effusion and tamponade.
Okay.
Rule in, rule out massive LAD, so that the LV would be massive and not contracting.
Yeah. Okay. So I would
but
see.
you see that on ECG.
So in the tamponade, I'd see an effusion, and I'd see signs of tamponade, and that's another case.
Yeah.
I might see just a dilated heart.
Yes.
And that's probably what we unfortunately most often see after a PA or a collapse arrest.
And then you look at the tummy. Is it a AAA in an older person?
yeah. Okay. So
free fluid.
and if
AAA.
it was a AAA,
Yeah.
I'd probably be seeing a hypercontractile heart.
Yeah.
Yeah. So
Hyperdynamic,
hyperdynamic,
everything's
yeah,
small,
yeah.
IVC small.
So it's PE, it's tamponade, it's a globally dilated heart, or it's a super contracting
Yeah.
heart. Yeah. So bang, bang, bang.
Yeah.
We got PE.
Yeah.
Let's go for that.
And see, this is the thing. Like now, you knew at the bedside what was going on.
Yep.
Like the clinical science didn't give you anything. If you didn't do echo, you'd have to wait for the CT to know what's going on.
Was there anything else you would do at this point
Yeah.
before you go to CT?
I check the lungs, because if you have a pneumothorax, it could become a tension in CT. Then if you see one, you did anyway.
So I already did. I started with, I did an ABC.
You check the aorta and the fluid.
Yes. Okay. So you go. So probably now, when I'm on the IVC, I could just go for the aorta to make sure there wasn't a AAA or free fluid. So some sort of intra-abdominal catastrophe.
And other people will say, "Oh, I checked the veins for DVT."
Well, I wonder
confirm
about
a
that.
PE.
Is that something? Is it useful? Should I be doing that?
If you're going to thrombolyze and you are still hesitant, maybe do it.
Yeah. Okay. Some more evidence.
Yeah, but
what I actually did was, I ordered a CT,
Yeah.
and then I just had a bit of a look at his legs, and I
Excellent.
just had a little bit of a clinical look to see whether he had an
And it looked
obvious
normal.
PE or DVT. So they looked normal, and he looked a bit kind of hectic and not. He looked older than his years, and my. I was thinking cancer. Really, that's what I was thinking. Yeah. So and look, sure enough, unfortunately, so went to CT, and he's got PE. He's got bilateral.
So you said they'd moved from saddle.
Yeah,
That's
moved
why.
from saddle. So that makes sense. So actually, the IVC
It was
might
your
have been
imaging.
right.
Yeah, the IVC was
Good.
right.
I'm glad it's not my imaging. That's fantastic. We're not sure. He's still in ICU. We're not sure what the underlying etiology was. He's okay. He's doing all right. Look, we heparinized him, didn't thrombolyze. You know why?
Why? Because he was on
trauma, man. He had such a broken chest. So and that's a discussion for another time. But I guess if he rearrested in front of me,
thrombolyzed,
probably would. Yeah,
because he's going to die anyway.
Yeah, it's going to die anyway. So so look, that's my case. I mean, that's that's the case of the week.
The best is that you save the images so we can talk about it.
Yeah, absolutely. All right. Well, thanks, Amali. So that's a case of post arrest. How do you sort out, what to do first, really, where to put the probe, what views to get, how to interpret those images, put the whole picture together, look at the H's and the T's and look at what it should be. And then we get a diagnosis.
At the bedside in 5 minutes.
5 minutes. And CT, it's just a load of blah, blah. Anyway, that's all from us.
See ya.